Welcome to Pediatric Case Review. Today's lecture covers Pfeiffer Syndrome, a rare genetic craniosynostosis disorder. We will explore clinical presentation, examination findings, pathophysiology, diagnostic approaches, treatment options, and complications. This intermediate-level review is designed for medical specialists. Let us begin our comprehensive exploration of this important pediatric condition. Question 1. A newborn presents with an unusual skull shape and broad thumbs noted at delivery. Physical examination confirms cranial abnormalities and digit anomalies. What is the defining feature of Pfeiffer syndrome? Option A, isolated craniosynostosis only. Option B, craniosynostosis with broad thumbs and toes. Option C, syndactyly without craniosynostosis. Option D, microcephaly with normal digits. The correct answer is B. Pfeiffer syndrome is characterized by the classic triad of craniosynostosis, broad thumbs, and broad great toes. This autosomal dominant condition results from mutations in fibroblast growth factor receptor 1 or 2 genes. The combination of cranial and digital abnormalities distinguishes Pfeiffer syndrome from isolated craniosynostosis and other syndromic forms. Question 2. An infant presents with craniosynostosis and broad digits. The skull deformity is mild, and developmental assessment suggests normal intelligence potential. Which Pfeiffer syndrome type best describes this presentation? Option A, Type 1 with mild features and good prognosis. Option B, Type 2 with cloverleaf skull. Option C, Type 3 with severe ptosis. Option D, Type 4 progressive form. The correct answer is A. Pfeiffer syndrome type 1 represents the mildest form with the best prognosis and typically normal intelligence. Type 2 features a cloverleaf skull deformity with severe complications. Type 3 presents with severe ocular ptosis and neurological problems. Only 3 types exist in the classification system. Type 1 patients often lead near normal lives with appropriate surgical intervention. Question 3. A neonate is diagnosed with Pfeiffer syndrome showing brachycephaly and midface hypoplasia on examination. Which cranial sutures are most commonly involved in premature fusion in this condition? Option A, sagittal suture only. Option B, coronal sutures bilaterally. Option C, lambdoid sutures. Option D, metopic suture alone. The correct answer is B. Bilateral coronal suture synostosis is the most characteristic finding in Pfeiffer syndrome, resulting in brachycephaly with a shortened anterior-posterior skull diameter. This pattern contributes significantly to midface hypoplasia. While multiple sutures can be affected in severe cases, bilateral coronal involvement defines the typical cranial appearance and distinguishes this syndrome from other craniosynostosis patterns. Question 4. A child with Pfeiffer syndrome undergoes clinical evaluation. Physical examination reveals distinctive facial characteristics. Which features are most characteristic of this condition? Option A, micrognathia and low-set ears. Option B, hypertelorism and midface hypoplasia. Option C, macroglossia and prognathism. Option D, facial asymmetry only. The correct answer is B. Hypertelorism, or abnormally wide-set eyes, combined with midface hypoplasia creates the characteristic facial appearance. Additional features include ocular ptosis due to shallow orbits, a high prominent forehead, and a beaked nasal configuration. These features result from premature coronal suture fusion affecting normal craniofacial development. The midface retrusion can cause functional problems, including breathing difficulties. Question 5. A newborn with suspected Pfeiffer syndrome undergoes detailed physical examination. The hands show distinctive thumb abnormalities bilaterally. What is the characteristic thumb presentation in this syndrome? Option A, absent thumbs. Option B, broad and radially deviated thumbs. Option C, duplicated thumbs. Option D, hypoplastic thumbs only. The correct answer is B. The thumbs in Pfeiffer syndrome are characteristically broad and widened with radial deviation, meaning they angle outward from the hand. Partial soft tissue syndactyly may occur between the thumb and index finger. The great toes show similar broadening. These digit abnormalities are part of the diagnostic triad and result from abnormal bone development during embryogenesis. Question 6. During examination of an infant with Pfeiffer syndrome, attention turns to the feet. What characteristic findings would you expect in the great toes? Option A, normal great toes. Option B, broad and medially deviated great toes. Option C, absent great toes. Option D, overlapping toes only. The correct answer is B. The great toes mirror the thumb abnormalities, appearing broad and widened with medial deviation into a valgus position. Syndactyly may affect the other toes. This digital phenotype involving both hands and feet is pathognomonic for Pfeiffer syndrome. The abnormalities result from the same underlying genetic mutation affecting skeletal development throughout the extremities. Question 7. A patient with type 1 Pfeiffer syndrome undergoes cranial examination. Head circumference measures within normal range, but the skull shape appears abnormal. What skull shape would you expect? Option A, scaphocephaly, which is long and narrow. Option B, brachycephaly, which is short and wide. Option C, plagiocephaly, which is asymmetric. Option D, normal skull shape. The correct answer is B. Bilateral coronal suture synostosis produces brachycephaly, characterized by a shortened anterior-posterior diameter and compensatory increase in skull width. The skull appears short from front to back and relatively wide. This creates the high, prominent forehead typical of Pfeiffer syndrome. The brain compensates by growing where sutures remain patent, creating the characteristic head shape. Question 8. A toddler with Pfeiffer syndrome presents for ophthalmologic evaluation. The eyes appear to bulge forward prominently, a condition called ptosis. What is the underlying cause of ocular ptosis in this syndrome? Option A, increased intraocular pressure. Option B, shallow orbits from mid-face hypoplasia. Option C, retrobulbar tumor. Option D, thyroid eye disease. The correct answer is B. Ocular ptosis results from shallow orbits that cannot adequately accommodate normal-sized eyeballs. This occurs secondary to mid-face hypoplasia from premature coronal suture fusion. The shallow orbital depth pushes the eyes forward, creating apparent bulging. This can lead to corneal exposure, drying, and potential vision loss. Severe cases require orbital advancement surgery to protect the eyes. Question 9. A 5-year-old child with Pfeiffer syndrome fails a routine school hearing screening. Audiologic evaluation is recommended. What type of hearing loss commonly affects patients with this syndrome? Option A, sensory neural hearing loss only. Option B, conductive hearing loss from ear anomalies. Option C, central auditory processing disorder. Option D, no hearing loss occurs. The correct answer is B. Conductive hearing loss occurs frequently in Pfeiffer syndrome due to narrow external auditory canals and chronic middle ear effusions. The craniofacial abnormalities affect normal eustachian tube function, predisposing to fluid accumulation. Regular audiologic monitoring is essential. Management may include ventilation tube placement and hearing amplification devices. Early identification and treatment prevents speech and language developmental delays. Question 10. A neonate with Pfeiffer syndrome develops noisy breathing with intermittent oxygen desaturations during feeding and sleep. What is the primary cause of airway obstruction in this condition? Option A, laryngomalacia. Option B, midface hypoplasia causing upper airway obstruction. Option C, tracheomalacia. Option D, vocal cord paralysis. The correct answer is B. Midface hypoplasia causes narrowing of the nasopharyngeal airway, leading to upper airway obstruction. Choanal stenosis may compound the problem. Many patients develop obstructive sleep apnea, requiring monitoring and intervention. Severe cases necessitate tracheostomy placement for airway management. Midface advancement surgery can improve airway patency in older children, but timing must be carefully considered. Question 11. A 2-year-old child with type 1 Pfeiffer syndrome undergoes developmental assessment. The child has received appropriate surgical management for craniosynostosis. What developmental and intellectual outcome would you expect? Option A, severe intellectual disability. Option B, normal to near normal intelligence. Option C, progressive neurodegeneration. Option D, autism spectrum disorder. The correct answer is B. Children with type 1 Pfeiffer syndrome typically achieve normal to near normal intelligence when intracranial pressure is properly managed with timely surgery. In contrast, types 2 and 3 carry higher risks for developmental delays and intellectual disability due to more severe cranial and neurological involvement. Early cranial vault expansion surgery significantly improves neurodevelopmental outcomes across all types. Question 12. An 8-month-old infant with Pfeiffer syndrome becomes increasingly irritable with frequent vomiting. Examination reveals a full, bulging anterior fontanelle. What do these clinical signs most likely indicate? Option A, gastroenteritis. Option B, increased intracranial pressure. Option C, dehydration. Option D, normal infant behavior. The correct answer is B. These symptoms indicate increased intracranial pressure, a serious complication of craniosynostosis where the fused skull restricts normal brain growth. Clinical signs include irritability, vomiting, bulging fontanelle, papilledema, and developmental regression. This represents a neurosurgical emergency requiring urgent evaluation and possible decompression surgery. Regular monitoring with clinical assessment and fundoscopic examination is essential. Question 13. During detailed hand examination of a patient with Pfeiffer syndrome, you notice webbing between certain fingers. What is the typical pattern of syndactyly in this condition? Option A, complete bony fusion of all fingers. Option B, partial soft tissue syndactyly, usually affecting second and third digits. Option C, only thumb to index finger syndactyly. Option D, no syndactyly occurs. The correct answer is B. Partial soft tissue syndactyly commonly occurs in Pfeiffer syndrome, typically affecting the second, third, and fourth fingers. The severity varies from minimal webbing to more extensive fusion. Similar patterns may affect the toes. Surgical separation may be considered for functional improvement, particularly when the thumb is involved, but the broad digit morphology remains the hallmark feature. Question 14. A child with Pfeiffer syndrome undergoes upper extremity examination. You assess elbow range of motion and find limitations. What elbow abnormalities may occur in this syndrome? Option A, normal elbow anatomy. Option B, radiohumeral synostosis is possible. Option C, elbow dislocation is always present. Option D, elbow hyperextension. The correct answer is B. Radiohumeral or radioulnar synostosis can occur in Pfeiffer syndrome, representing fusion of forearm bones that limits rotation. Some patients develop ankylosis of the elbow joint with restricted flexion and extension. These skeletal abnormalities vary in severity and do not affect all patients. Upper extremity radiographs can identify these bony fusions and guide functional therapy planning. Question 15. Parents of a child with Pfeiffer syndrome request genetic counseling regarding future pregnancies and inheritance patterns. What is the genetic basis of this syndrome? Option A, autosomal recessive inheritance. Option B, mutations in fibroblast growth factor receptor 1 or 2 genes. Option C, chromosomal deletion. Option D, X-linked inheritance. The correct answer is B. Pfeiffer syndrome results from mutations in the fibroblast growth factor receptor 1 or 2 genes following autosomal dominant inheritance. These are gain-of-function mutations causing premature bone differentiation. Most cases represent de novo mutations, meaning new mutations not inherited from parents. However, affected individuals have a 50% chance of transmitting the mutation to offspring, warranting genetic counseling. Question 16. During a research conference, the molecular mechanism of craniosynostosis in Pfeiffer syndrome is discussed. How do fibroblast growth factor receptor mutations cause premature suture fusion? Option A, decreased bone formation. Option B, premature osteoblast differentiation. Option C, cartilage destruction. Option D, decreased calcium absorption. The correct answer is B. The fibroblast growth factor receptor mutations in Pfeiffer syndrome are gain-of-function mutations that cause premature osteoblast differentiation and accelerated bone formation. This leads to early fusion of cranial sutures before brain growth is complete. The expanding brain then encounters a rigid, non-expandable skull, potentially causing increased intracranial pressure and abnormal skull shape as growth redirects to patent sutures. Question 17. A newborn with clinical features suggestive of Pfeiffer syndrome requires radiologic evaluation to assess cranial suture status. What is the appropriate first-line imaging study? Option A, magnetic resonance imaging of the brain. Option B, skull radiographs. Option C, positron emission tomography scan. Option D, ultrasound only. The correct answer is B. Skull radiographs serve as the initial imaging modality, demonstrating fused cranial sutures and characteristic skull shape. Multiple views, including anteroposterior and lateral projections, are obtained. While computed tomography provides superior detail, plain radiographs offer a cost-effective screening tool. They show the classic copper-beaten appearance of chronic increased intracranial pressure when present and clearly delineate suture fusion patterns. Question 18. A 6-month-old with confirmed Pfeiffer syndrome is being evaluated by craniofacial surgery for potential operative intervention. What is the primary role of computed tomography scanning in this clinical scenario? Option A, no role for computed tomography imaging. Option B, detailed suture anatomy and surgical planning. Option C, assess liver function. Option D, evaluate kidney development. The correct answer is B. Computed tomography with three-dimensional reconstruction provides detailed visualization of cranial bone anatomy, clearly showing which sutures are fused and the extent of deformity. This information is crucial for surgical planning, allowing the craniofacial team to design the optimal approach for cranial vault reconstruction. The three-dimensional images help parents understand the planned procedure and expected outcomes. Question 19. A family with a clinically diagnosed child seeks definitive diagnostic confirmation and information for family planning. What test provides confirmatory diagnosis of Pfeiffer syndrome? Option A, complete blood count. Option B, molecular genetic testing for fibroblast growth factor receptor mutations. Option C, liver function tests. Option D, karyotype analysis only. The correct answer is B. Molecular genetic testing through sequence analysis identifies mutations in fibroblast growth factor receptor 1 or 2 genes, providing definitive diagnosis. This testing confirms the clinical diagnosis, enables accurate genetic counseling regarding recurrence risk, and allows prenatal diagnosis in subsequent pregnancies if desired. Testing both parents can determine whether the mutation is inherited or arose de novo. Question 20. A 3-year-old child with type 2 Pfeiffer syndrome and severe ocular ptosis undergoes ophthalmologic evaluation. What are the primary ophthalmologic concerns in this condition? Option A, no eye problems occur. Option B, exposure keratopathy and vision loss risk. Option C, retinal detachment only. Option D, color blindness. The correct answer is B. Severe ptosis prevents complete eyelid closure, causing exposure keratopathy where the cornea dries and becomes damaged. This can lead to corneal ulceration, scarring, and vision loss. Amblyopia may develop from anisometropia or strabismus. Management includes frequent lubricating eye drops, nighttime ointment, possible temporary tarsorrhaphy, and orbital advancement surgery in severe cases. Regular ophthalmologic monitoring is mandatory. Question 21. Parents of a 6-month-old with Pfeiffer syndrome meet with the craniofacial surgery team. They ask when cranial vault reconstruction should optimally be performed. What is the recommended timing? Option A, wait until adulthood. Option B, 6 to 12 months of age. Option C, after age 5 years. Option D, never operate. The correct answer is B. Cranial vault reconstruction is optimally performed between 6 and 12 months of age. Early surgery prevents increased intracranial pressure that could damage the developing brain, allows unrestricted brain growth during critical developmental periods, and takes advantage of young bone's superior remodeling capacity. Delaying surgery risks irreversible neurologic damage. Some severe cases require even earlier intervention. Question 22. An 8-month-old with Pfeiffer syndrome is scheduled for cranial vault reconstruction surgery. What is the primary goal of this procedure? Option A, cosmetic improvement only. Option B, create adequate space for brain growth. Option C, treat hearing loss. Option D, repair hand abnormalities. The correct answer is B. The primary goal of cranial vault reconstruction is creating adequate intracranial volume to accommodate normal brain growth, thereby preventing increased intracranial pressure and neurologic damage. While improved cosmetic appearance is a welcome secondary benefit, the fundamental purpose is functional, protecting the brain during critical developmental periods. The procedure involves removing fused bone, reshaping the skull, and allowing sutures to remain open. Question 23. A 5-year-old child with Pfeiffer syndrome who underwent cranial vault reconstruction as an infant continues to have significant mid-face hypoplasia affecting breathing and appearance. When is mid-face advancement surgery typically performed? Option A, simultaneous with initial vault surgery. Option B, later in childhood, around age 5 to 7 years. Option C, never performed. Option D, in infancy before vault surgery. The correct answer is B. Mid-face advancement surgery is typically performed later in childhood, usually between ages 5 and 7 years, after completing cranial vault reconstruction. This staged approach allows initial focus on protecting the brain, then addressing mid-face protrusion once facial growth provides adequate bone stock. The procedure, often a Lefort 3 osteotomy with distraction, advances the entire mid-face forward, improving both airway function and facial appearance. Question 24. A toddler with Pfeiffer syndrome has thumb to index finger syndactyly affecting pincer grasp. The family asks about surgical options for the hands. What are appropriate indications for hand surgery in this syndrome? Option A, always required. Option B, functional impairment or severe syndactyly. Option C, never performed. Option B, only for cosmetic reasons. The correct answer is B. Hand surgery is indicated when syndactyly or thumb abnormalities cause functional impairment affecting grasp, pinch, or fine motor skills. Procedures typically involve syndactyly release and soft tissue reconstruction. Surgery is generally performed between ages 1 and 2 years. Thumb involvement is prioritized as it most significantly affects hand function. The broad digit morphology persists, but function typically improves substantially. Question 25. An infant with type 2 Pfeiffer syndrome experiences severe obstructive sleep apnea with oxygen desaturations. Continuous positive airway pressure therapy fails to provide adequate ventilation. When is tracheostomy indicated in Pfeiffer syndrome? Option A, never indicated. Option B, severe airway obstruction unresponsive to other measures. Option C, routine in all cases. Option D, only for vocal cord paralysis.